So welcome to this tools and technique dedicated to the new Evolut PRO Plus platform. So it's going to be a very interesting session about this new device. My name is Didier Cheche, and I have the great privilege to share this session with friends of mine. So we have Dan Blackman. Hi, Dan.
Hi, Didier.
We have Tanya Rudolph. Hi, Tanya.
Hi.
And Azim Latib, that you all know. Hi, Azim.
Hi, everybody.
So the TNT today is going to be built around a recorded case that we're going to see, showing all the advantages of the Evolut PRO Plus platform. So what are the learning objectives today? So maybe we can pop up the slide. Today what we will try to aim at is first to explore the benefits of the new Evolut PRO Plus platform and explore its versatility to treat different patients' anatomies. We've seen a bicuspid case that was performed 2 hours ago, and we're going to see how it performs in more regular anatomy. One of the second objective is to try to understand how the cusp overlap, the combination of the cusp overlap technique and the commissural alignment, more contemporary techniques dedicated to this platform, can help to ensure optimal outcomes and future coronary arterial access for our patients. And at last, we will try to discuss the benefits of that platform that we know, that self-expanding supraannular platform in low-risk patients, because this is one of the last indications, apart from bicuspid patients. The low-risk indication is one of the most recent indication for TAVI in general. So I would like to remind you that this remains an interactive session, so I strongly encourage you to populate your questions through the chat, and we will answer them during that TNT. So the chat master is Sonia. Hi, Sonia Petronio, and she's going to answer your questions, and we're going to bring some of them live just to discuss them. So I guess we can start. We're going to start with you, Dan. You're going to drive us through the features of the Evolut PRO Plus, and we're going to understand more about the architecture of that platform, what it brings in terms of novelties. So the floor is yours, Dan, for your lecture on the Evolut PRO Plus design.
Good afternoon, everyone, and thank you to the organisers of EuroPCR and to Medtronic for inviting me to give this short talk on the Evolut PRO Plus valve iteration and the design advancements that will make a difference. My name's Dan Blackman. I'm an interventional cardiologist and TAVI operator from Leeds in the UK. These are my potential conflicts of interest. So as you know, we've seen a number of iterations of the core valve Evolut platform over the years since we started TAVI. We started off with the core valve system delivered via an 18 French sheath and not repositionable or recapturable. The first big development was Evolut R. This gave us repositionability through recapturability and the introduction of a sheathless approach, which meant we were down to a 14 French equivalent and could treat patients with vessel diameters as low as 5 millimeters. This came in the 4 sizes shown on this slide. With PRO, a number of years ago, there was the addition of an external pericardial wrap as well as the inner skirt, mitigating paravalvular leak with demonstrable improvements in PVL outcomes. But this was at the price of a slight increase in caliber of the capsule, which translated to an increase in the necessary vessel diameter to 5.5 millimeters, slightly changing the number of treatable patients. So what do we have with PRO Plus that we're talking about in this session today? 2 key changes. Firstly, the addition of the pericardial wrap to the 34 millimeter valve. And secondly, the reduction in the caliber of the outer of the capsule, which is now down back to 6.0 millimeters, meaning we can again treat patients with the 3 smaller valve sizes with vessel diameters as low as 5 millimeters. So if we look first at the frame, the only change with Evolut PRO Plus is the addition of the pericardial wrap to the 34 millimeter size. There's no change in the other valves. There's no change with any of the valves in the frame or the inner tissue. As a reminder, this external wrap covers the first 1.5 inflow cells or diamonds and extends to the base of the frame, giving around 14 millimeters, varying slightly from valve to valve size. We already have data, and these are being presented at this conference for the first time and are available for you online from the TVT registry, showing that this pericardial external wrap does translate to reduced PVL. These data are across all valve sizes from the US TVT registry, where the Pro Plus system has been available for some time. And if you look at the right-hand panel, you can see when we compare Pro Plus to Evolut R, this is with 1 month site-performed and reported echocardiogram, that there's a highly significant reduction in mild PVL, an increase in none or trivial PVL. No change in the very small 2% of patients with moderate or more. What about the reduction in the size, the diameter of the capsule? How's this been achieved? This is a cross-section of the capsule. You can see the capsule consists of a nitinol frame, which provides support. Previously, both on external and internal to the nitinol capsule was a silothane layer, and this provides flexibility, which aids in deployment and recapture. And what's changed with Pro Plus is the replacement of the inner silothane layer with a PTFE capsule liner. This has much lower friction and essentially means you can fit the same sized valve into a smaller space. So the only thing that's changed in size, in diameter, is the lumen. The thickness of the wall of the capsule, if you like, is the same, but the reduced friction of the PTFE inner liner means you can fit the same sized valve into a smaller space. So if we look at this in detail, this means that with the 3 sizes, 23, 26, 29, the capsule outer diameter has changed from 6.7 to 6.0. This means we can treat patients with vessel diameters down to 5.0. With the 34 millimeter valve, the addition of the pericardial wrap actually means an increase in outer capsule to 6.7 to 7.3, meaning we can treat patients down to 6.0 millimeters, 18 French, so a slight increase in size, but these are, of course, generally larger patients with larger access vessels. What does this mean for our patients and for our practices? Well, these are data from the Evolut low risk and Satavi trials, and they show that around 10% of patients being treated with 23, 26, 29 valves had vessel sizes between 5 and 5.5. These patients previously required the Evolut R system because they needed 14 French equivalent, but now this is another 10% of patients that can benefit from the pericardial wrap in the Pro Plus. So in conclusion, with Pro Plus, we have a reduced capsule diameter for the 3 smaller sizes, reducing the required vessel diameter 5 to 5.0 millimeters, increasing the number of treatable patients, and should also translate to reduced risk of vascular access complications across the board. The 34 valve now benefits from the pericardial wrap, and early data confirm what we'd expect, that this translates to reduced paravalvular leak and better outcomes for our patients. So thank you for your attention, and we'll look forward to moving on to the recorded case demonstrating a Pro Plus valve in action.
So thank you very much, Dan. This was a clear overview of the features, the novelties of the Evolut PRO Plus platform. It has been recently CE marked, very recently CE marked. So most of the experience resides in the US so far. So maybe I could start with you, Azim, because you have experience with that platform. And I'm going to ask you one question from the audience. It's about the additional wrap that has been added to the 34. Is there a price to pay in terms of risk of coronary obstruction? Because we are aiming extremely high now, and we're going to see that potentially during the recorded case. We are aiming higher and higher. That wrap that is now available for all 4 valve sizes, does it impact the risk of coronary obstruction?
Yeah, I think that's a good question. In my experience, I don't think the risk of coronary obstruction has been increased by that wrap, because remember, the wrap's on the outside. It's covering an area we had already, right? So we're not seeing increased obstruction because of the wrap. I mean, I do think as we go higher and higher, obviously, doing your analysis and the CT analysis and looking at coronaries becomes very important, because there will be maybe a small subset of patients where you don't want to be too high and you want to make the best use of the constrained part of a Medtronic core valve. But certainly no issues with the wrap, and we've not seen any higher risks of coronary obstruction or even malposition of the valve since using PRO Plus.
Thank you, Azim. Very clear statement. So let me come back to you, Dan. Dan, so you nicely demonstrated the new features of the Evolut PRO Plus. So we all have the feeling that it's going to enable the treatment of a larger group of patients. More patients are going to benefit from a transfemoral procedure. So do you think that there could be specific subgroups that could benefit first from the improved profile? And second, from the additional wrap on the 34, the larger valve sizes? What do you foresee in terms of additional indications?
Yeah, it's a good question, Didier. I mean, I think if we take the wrap first, I think, we could probably all agree that enlarger anatomies are frequently often accompanied by more hostile anatomy in terms of calcification, particularly when we get into bicuspid valves, which frequently have larger annuluses, and we're looking at treating them with the larger size devices. So I think that's certainly a group, the large annulus bicuspid patients, where the wrap will provide extra benefit. And I think, I was a little bit skeptical about the wrap at first, because it is just one single pericardial layer, but I'm pretty convinced now that we've seen an improvement. In our own UK national registry data, we showed moderate PVL halved in 2 successive registries, one with R and then one with Pro. So I think we are going to benefit from less PVL, and it's those large annuli, and especially I think the bicuspids. In terms of the access size, I showed that you can probably treat about 10% more patients with the 14 French system that previously you couldn't treat with the 16 French Pro. So that means more patients. But if you look at vascular access complications, plenty of data has shown there's a relationship between the ratio of the vessel size and the caliber size of the system that you're introducing. So if we reduce the caliber size, whatever size the vessel is, we should be reducing vascular complications. And of course, we all know that vascular complications are still by far the most common complications of TAVI.
Okay, excellent. So maybe we can move forward and directly dive into the core of the subject and through the recorded case. And so, Azim, we are looking forward to hearing which type of patient you are going to present today.
Hello, everybody. My name is Azim Lateeb from Montefiore Medical Center in New York, and it's my pleasure to present today this recorded case of an Evolut PRO Plus on behalf of my colleagues here at Monte. This is our patient. She's an 88-year-old female with a previous medical history of spinal stenosis, some obesity, osteoarthritis, hyperlipidemia, and hypertension, who presents now with severe aortic stenosis. Her main symptoms are dyspnea and exertion, and as well as orthostatic dizziness and orthopnea. She's an NYHA3. As you can see from her medical history, she really doesn't have much as far as comorbidities or important risk factors. We called her intermediate risk based on her age, but she may even qualify as being really low risk. A transthoracic echo shows an ejection fraction of 65%, a mean gradient was 36, peak 64, and an aortic valve area of 0.7. We did a coronary angiogram, which showed non-obstructive coronary artery disease. Her renal function is normal with a GFR of 61. And if you look at her ECG, she has normal sinus rhythm, a PR interval of 158, and a QRS of 76 milliseconds. So this is her CT evaluation, which shows, if we look at her annulus, she has a perimeter of 68.5, which gives you a perimeter-derived diameter of 21.8, a mean diameter based on minimum and maximum diameter of 21.4, and her area of the annulus is 368.8. Alveolar T gets slightly smaller. If you look then at a sinotubular junction, about 26 millimeters, her sinuses of Valsalva are large. They 27 to 29 millimeters. Her coronary ostia also at an acceptable height, 13.5 for the left and 15.5 for the right. When you look at her right and left iliofemoral access, she really has good MLDs bilaterally, so you could really use either the right or left access for a TAVR. So according to this evaluation, we thought she's a good candidate for a 26 millimeter Evolut PRO Plus transcatheter valve. We were going to use her right femoral artery for valve delivery, her left atrial artery for pigtail and aortography, and body protection with a sentinel device was employed during the case. Thank you.
Good day, everyone. Welcome to Montefiore Medical Center and the structural heart team here. It's a pleasure to have you join us for this transfemoral TAVR today with a core valve Evolut PRO Plus. I'm Azim Latib. On my left is Mei Chow, who's my surgical partner and the first operator in this procedure. Jesus Montezino, who's our tech. And then we have a great support team, Stephanie, Shireen, and Jalissa, who are supporting us, and Liz, our anesthesiologist, who's helping us for this case today. So now, we've got our protection in place. We need to do a cardiac cath on this patient too. There's left Jackins? Yeah. Okay. We're going to swap very briefly as we do a left heart cath. This patient's coronaries looked fine on the CAT scan, but we didn't see lots of calcium or anything, but at the same time, we did need to document that she had no coronary disease. Can you go up to 22, please? Thank you so much. Okay, great. Okay, good. So this is a JL4, right? JL4. So essentially, if we then afterwards have time to cath this patient again, we should use one size smaller because this fits really perfectly. Okay. Okay? Perfect. We'll do that pretty fast. And really, we just got to confirm what we saw in CAT scan, flush. That, there's really no significant disease. Okay, great. Okay, fill up your catheter, please. Okay, great. Ready? Okay. So very short left main, almost two separate ostia for the circumflex and LAD. It looks like it could be a dominant circ. Okay. But I really do not see anything significant. Let's just look at the LAD better. Really nothing. And it looks like it's either dominant, co-dominant. You see a PDA there. Okay, I think that's all we really need. Huh? What do you think? Yeah. Okay, a little puff, please. Okay, so it's a really small RCA. We'll take one picture of this, but I think, this is an RCA that we don't need to look at afterwards again if we decide to just show what coronary access looks like. It's really a non-dominant RCA, and very small, so. Okay, great. Okay, so let's do a baseline aortogram in our coplanar view, and then we'll get another one in a moment in our other view. So that looks like a pretty good view. 22, big enough? Yeah, I think so. Okay. Ready? Oh, no, it's okay. Go ahead. Okay. I think it's going to be a beautiful view. Okay, so nice coplanar view. You see the calcification. They're in the center, predominantly on the right coronary cusp. So now we'll exchange out the sheath, and we're going to go with our Evolut PRO Plus. Okay. So really importantly here, Jesus is going to show you how he's holding it at the back. Remember, we now no longer hold it with a flush port. Point to the flush port, Jesus. Facing 12 o'clock. How do we, before we used to go in like this, right? Now we go in with a flush port to the side at 3 o'clock. And I'll show you that when we get in, this is what allows us and helps us with commissural alignment and to get that commissure away from the left main. Okay. Good, I've got wire. Is it going in easily, May? Okay, good. So, what we're going to do is once May comes up to a little higher on the descending aorta before crossing the arch, we're just going to mag up a bit here and look at our hat marker. I'm going to go into LAO view, so it's best to go into LAO view here. Laura? So, I'm just going to rotate a bit to see where our hat marker is. And you can see the hat marker there. Let me just rotate so you can see this. Okay. Okay, you can see the hat marker is on the outer curve of the aorta. And so that's, you can stop Flora now, thank you. And if it's an outer curve now on the right of the picture, when we go around the arch, it's going to end up on the outer curve of the aorta, which is where we want it to be. Remember, the hat marker is 90 degrees to where the C-tab is, and this will hopefully get the C-tab to be facing us and see us. Okay, so we can see the C and the C-tab and keep the commissure away from the left main. Okay, so I'm going to go into slightly smaller projection.
You have your A, correct?
Okay, and we'll cross the arch here in our LAO view. Okay, yeah. Great, so you have to usually pull a little bit on the wire at this stage, just to help they come around. Okay, stop there. Let's mag up again. All right. And you can see our hat markers on the outside. That's exactly where we want it to be. Okay.
So lots of information provided here, and so maybe Tanya, do you have any concern or any point of discussion that you would like to raise for this patient, having seen the patient presentation and the first steps of the procedure?
Yeah, I just want to thank Asim for this great case so far. I think it's a perfect candidate for a transfemoral TAVR receiving an Evolut regarding the small annulus. And I think you showed very nicely the steps so far we should keep in mind when we are using the Evolut PRO system, especially in regard to coronary access. So my question would be, what percentage of cases would you think that it actually really works when you turn the flush port to 3 o'clock outside the patient, and in the end you really end up at the correct position with the head on the outer curve? So what is your experience here?
Yeah, I must admit, we've started doing it routinely now, Tanya. We keep it on the outer curve, and we make sure it stays on the outer curve. I guess in most cases, we've been very happy. You can see the actual C-tab, and as long as you're seeing the C-tab, it probably means that your commissure is away from the left main. It's rare. I have to be very honest that it's rare that I pull the valve back and start rotating and do it again, unless I'm dealing with a specific case. So if I'm doing a challenging valve-in-valve or small annulus with low coronaries, I really make more of an effort then. So if I see that the head marker is not on the outer curve, I'll come back into the descending aorta, rotate it, try and get it on the outer curve again, and do that again. I have to admit that when you see the C-tab and you actually can see it and you try and cannulate the coronaries, it's not that difficult. It just makes it a little bit easier.
I absolutely agree. So I think this would be my question at the moment, and I think we should go on with the case.
Okay, so let's resume the video. Thank you.
Okay, stop there. So you see, I think the best thing with this is to really try and keep it as neutral as possible and let the valve do the work of dropping down. Okay, so I like that again. We can do a little cine here with a little puff again. Little puff. Good. I like that. What do you guys think?
Yes.
Okay. Okay, there's a little forward pressure there. Okay, not too much though. Okay. So that is going to go down. Pace, please. Maybe even on 140, please. Yeah. Yeah. Keep forward pressure, mate. Okay, stop pacing. Keep a little forward pressure. She has these big ectopic beats, huh? Okay. So that's looking pretty good. It stayed where we wanted it to in relation to that pigtail. A little forward pressure. Okay. Let's see. Okay, so let's do a little audiogram here, and then we'll go into an LAO view and to our coplanar view. Okay, go ahead.
Ready?
Yeah. Little puff. Good, looks good. Stop there. I really like that. You can see, you know, we're fine on the non. We're a little lower on the left, which is kind of what we expect. Let's go to our coplanar view, and then maybe we'll go to an LAO as well. Okay, let's have a look here. Okay, we'll do a little puff here again, since this is what teaching. Little puff, stop there. I really like this, guys, and it just shows you, you know, as someone who's a late adopter for the cusp overlap, I think this shows you how you can get fooled in other projections because you can end up, you know, being too low, and this stops you from being too low. I'm just going to go to LAO 20, but I think this is the view we'll release in, which is the coplanar view. Floral. So you see, I think we're fine on both. Let's go back to our coplanar. So blood pressure is okay. What does everybody think? Yeah, we're happy to release? Okay. So, Flora, what we're going to do is May's going to just hold a little forward pressure, but I already like it because you see the delivery system is in the center of the aorta. Flora, I'm going to pull back on the wire so there's nothing pushing the valve up as we release. Okay. And we slowly release. We really take our time here. Especially in a patient that is having lots of ectopic beats. Okay, so it released the one tab. Still got to release the other one. There we go. Let's stop there. Save fluoro, so they both released. Okay, and the valve stayed very, very stable. Okay. Okay, great. Now look at the C mark, the head mark. The commercial tab, the C marker. You can actually see a C. Okay. What's it called? C tab? C tab. C tab. You can see a C, which kind of would suggest that we're far away from the left main, and that there's no commissure in front of the left main. So I think, you know, we achieved the two things we wanted to do here. We did a pretty high implantation. Let's see what the result is. And we did commercial alignment to get that C-tab away from where the left main is. Let's take this out and put our 14 French sheath in. Okay? That way we can go back and do another coronary angiogram at the end. Okay? Okay, so let's look at echo now. You can stop floor. Yeah, it's really great position.
There you are. Thank you.
Yeah, I'm not seeing any PVL2 on this view, on this parasternal long. Yeah, I mean, I have to admit there, you know, a lot of centers now that are not doing transthoracic echo at the end of the procedure. They're just making their decisions based on fluoroscopy. We still believe really strongly that you need all the modalities to evaluate patients because we really want to give our patients the best results possible. I mean, this is a patient who's essentially, you know, even though elderly, low risk, and Dr. Chow wouldn't accept from me, you know, from us, a suboptimal result. So I think we learn more when we do TE, don't you think?
D'accord, merci. Ils ont l'air un peu perplexes aussi. Ouais. Ok, vas-y. C'est Azim. Donc Azim. Mais
Looks really good, yeah, I think. Yeah, it looks really good. As you can see, I think we may have lost audio, but you can see the 5-chamber view and 3-chamber view. I'm really not seeing any PVL, really no indication to post-dilate. We use, like I said earlier, we use transthoracic echo all the time in these cases. We evaluate our gradients at the end of the procedure as well, just to have a echo gradient that we can then compare at discharge when the patient's moving around a lot more, and then at follow-up. So in a second, I think we'll show you an audiogram too. We'll do a final audiogram, and in this case, we really wanted to show the advantages of commissural alignment and how, even though we have a tall valve, it doesn't impact in a big way coronary access, particularly if you optimize commissural alignment. So we'll give you an audiogram now to really have a sense of what the result looks like as well. So here you see the audiogram. I think you see a couple of things. Really good position of the valve, high implantation. You can see both coronaries and good coronary flow. I really don't see any PVL on aortography either. And then just, I always try and look at around everything. The aorta as well looks good. I'm not seeing any issues there. So it looks like a really great result, really maximizing the commissural alignment and using cusp overlap to get a high implant. And with Pro Plus and these techniques, we really have seen an improvement in PVL. So this is a low-risk patient. I really wanted to demonstrate here that getting coronary access is not a challenge. So we decided to recannulate the left coronary live to show you. So this is live. I often like to go with a wire, goes through the valve into the ventricle to be shown inside the valve. Before this really confirms that I'm within the core valve, right? I think this is a good trick to use in the future. Then pull the wire back and just watch the timer, how long it takes us to cannulate this coronary. So it's one attempt. I used the Judkins 3.5, so slightly smaller than what I would have used if there was no valve in front of me. So pulling back a little bit of clockwise, counterclockwise rotation to watch the really tip go through the valve strut, and there you see it pop through the valve strut, and we're in the coronary. I mean, that took literally 20 seconds to do. And this is why I think it makes, the extra effort of doing commissural alignment is beneficial. We're always going to have to get through the struts, but if we can at least keep the commissure away, it makes access that much easier. So we don't obviously routinely recannulate the coronaries. We're just doing this to demonstrate it added only 5 cc's to the procedure.
Azim, I just support your point on transthoracic echo. I mean, we seem to have gone full circle. We started off with people only doing echo and not doing aortograms, and now we've got people doing only aortograms and not echo. And there's valuable information from echo, from the aortogram, and from the hemodynamics. So we will always assess all three and get as much information as we can to get an optimal result. And I think, as I recall, you said if we had the audio from the tape, the other reason you need the echo, of course, is if anything happens, if we get sudden hypotension, and you can pretty quickly demonstrate what's going on and whether there's any concerning complication that needs addressing immediately.
Yeah, absolutely. What we do is we actually do we always do an echo before starting the procedure. It kind of also just helps you with when you look at the valve and you look at the ventricle at the end, understanding, is this a patient with a small ventricle? Are they going to need fluids at the end of the procedure to expand that ventricle? You see that small pericardial effusion the patient already has that's chronic, and you don't freak out at the end of the procedure because you see a small pericardial effusion, right? So it just helps with all of that. And by having it in the room all the time, when there's a complication, when there's sudden hypotension, it's not like somebody's looking for where the echo machine is. It's right there, it's on, you just grab the probe, and within seconds, you can exclude some of the important complications.
So thank you very much, Azim. So that was an outstanding case, and I definitely believe that it nicely demonstrates the features of the platform and the benefits, because this was a challenging patient. So there are several points of discussion that we may have here, but let me start first with the anatomy of the patient, because this is a challenging anatomy because it's a small annulus. So do you believe that, or do you think that there is an advantage of such a platform in such a small anatomy? Because the smaller the anatomy is, there are certain complications that you may develop for us. And so potentially some platforms may be more suited to small annuli rather than the other ones. What is your opinion on that?
Yeah, absolutely. So certainly in my practice, I'm a strong believer in using supraannular valves in small anatomies. I don't like very small intraannular valves, so I don't implant 20 millimeter valves in my patients. I think I may have done it once in my career so far. I try and avoid that, and I try and give somebody as big a valve as possible. You know, the one issue you have to take into account when dealing with small annuli is the fact that if it's a small annulus, it's a small anatomy, they have smaller sinuses, and so you need to think about coronaries as well. And while we're always trying to go higher and higher, you know, some of these patients, you may not be able to get as high as you like because of coronaries. So that's the only thing, the downside, you know, or the other side of the coin to take into consideration with small anatomies.
So very clear. So I would like to address one of the questions from the audience, because there you nicely demonstrated the new features and particularly the wrap and for the larger valve sizes. And one of the questions from our friends from the audience is about the ability, the potential for even higher implants as compared to what we are used to do with the contemporary, the last iteration. So Dan, do you think that with this new iteration of the Pro Plus, with the technique that has been demonstrated by Azim, we could aim higher, or is it a little bit dangerous, harmful for the patient? What is your opinion on that?
Yeah, I don't think the addition of the wrap Didier makes a difference to how high we go. They're separate but complementary features of the Evolut PRO Plus system. The reason we're going higher is to try and primarily to reduce pacemaker rate. And it's worth keeping that in mind. And we haven't touched on measuring the membranous septum, but that's always useful, and probably most useful, I think, when you find those patients with a long membranous septum. And then you don't necessarily need to go as high. If the membranous septum is 6 millimeters, then you can be looking at, not feeling focused on a high implant. Implanting high in general is definitely the right way to go. Don't get me wrong on that. I think, it primarily reduces pacemaker rate. It also increases the diameter of the frame at the level of the annulus, and therefore increases the radial force, and therefore will also contribute to the reduction in paravalvular leak. Set against that, as Azim said, we've got to think about coronary access, especially in small anatomy. And when we move into younger patients, we've got to think about TAVI and TAVI for the future as well. And we know that the patients that are going to be hardest to treat with a system like the Evolut in the future are those who have a low and small STJ. And if we implant higher in those patients, we may create problems for ourselves in the future. So we've got to focus now increasingly as we move into TAVI in younger patients about the next procedure as well, and making sure that we're leaving ourselves room both to reaccess the coronaries, but also to perform TAVI and TAVI in younger patients with longer life expectancies.
So it's let me bounce on that, the last part of your question, your comment, because you're discussing the issue of younger patients with lower risk profile, and we all have started to treat lower risk patients. And so, Tanya, this is a question for you. Do you think that the hemodynamics plays a role in the decision making for a low risk patient, given the younger age and the longer life expectancy? Do we have to focus on the hemodynamics, or do you think that this is not this should not be the core of the decision?
I definitely think that the hemodynamics they are very important, and no matter how old the patient is or what the risk of the patient is, we should always try to shoot for the best hemodynamics. But of course, If the hemodynamics are not perfect, there might be accelerated degeneration of the prosthesis. We definitely should avoid patient prosthesis mismatch, since it has been shown in surgical patients that this is an accelerating factor for valve degeneration, and it's very likely that we see the same in TAVI prosthesis. So I definitely think that in a small anatomy, it's even more important to be careful in selecting the right TAVI prosthesis for the patient, and to make sure that we have a perfect hemodynamic at the end of the procedure and also during the follow-up.
So thank you very much for that. So Azim, once again, if we try to address the concerns from the audience, you nicely demonstrated how to understand the position, the location of the heart marker to try to figure out if you have a proper commissural alignment or not. Could you once again explain that for us and for the audience? What should be the appearance of the heart marker in both the LAO and the RAO projection? And the second part of the concern, the second type of concern, is about do you try to align that as a position of the heart marker with the orientations of the coronary of a specific patient, because there is a wide variety of the angles. And do you try to adapt to that, or do you always put the flush port at 3 o'clock for every single patient?
Yeah, that's a great question. And I think, certainly in my practice, I try to keep it as simple as possible. I think in the future, we probably will learn more. As we learn more about commissural alignment, we may get patient-specific commissural alignment. There's a lot of work happening with that. I don't think we're there yet. So I keep it pretty simple. I just try and make sure that as much as possible, the head marker is on the outer curve when I'm in an LAO projection, because remember, in the LAO projection, that's when you're really going to have the left main on the opposite side. And generally, if I can see the head marker on the LAO projection, I'm happy, and that's where I'm going to implant the valve. Now, there are ways to look at it as well in your cusp overlap view, but I honestly try to keep it as simple as possible in my practice.
Okay. And so if we come back,
what do you do, by the way? Didier?
I do the same. So keeping the flush port at 3. There is only one type of situation in which I modify the technique. It's for bicuspid patients. For bicuspid patients with a fusion between, for example, the right and the non-coronary cusp, the location of the raphe is going to be different. So in that situation, I used to put the flush port between 6 and 9 o'clock, just to try to get a different position of the heart marker and the C-tab at the end of the procedure to keep the coronary osteums free. So this is still work in progress, but it's I like your advice of keeping it simple and keeping the flush port at 3 o'clock. For the vast majority of the patient, it's going to match that commissural to get a proper commissural alignment. If we come back before your lecture, Tanya, about the cusp overlap and the benefits of the cusp overlap. If we go a little bit more into details about the steps of that cusp overlap technique, would you refresh for us, Azim, what are the steps? Where do you place the ring of the capsule at the start? And what are the key steps for the audience, just to make it clearer?
Right. So, generally now, you will advance your valve, the core valve, across the native valve in the cusp overlap view. The cusp overlap view, as you know, is generally in an RAO oblique, RAO caudal view. And even for those of you, and I honestly mean this, I'm a late adopter of this, so I'm learning too here, on how to do this. And the reason I like it is because, compared to the old technique we did, in the cusp overlap view, it's the view that gives you your alignment on the valve plus the alignment on the core valve. So you see the bottom of the marker of the core valve in a straight line. And that's what makes this view so powerful, I think. I used a Safari wire, as you saw in most cases. There are other centers that prefer using stiffer wires. I prefer the Safari wire, pre-shaped wire, or any other pre-shaped wire, because I'm very concerned about annular rupture. So I bring the valve across. I have my pigtail in the non-coronary cusp, and I have the bottom of the delivery system just above the pigtail. Because what you're doing is, as you're releasing the valve, we all used to complain about the fact that core valve moves forward. Right now, we actually use that to our advantage. We stay a little above the annulus and allow the core valve to move forward to engage the annulus. So by staying slightly above, just above the pigtail, when it opens up, it actually lands then on the annulus. When I see both sides opening and starting to engage the other end of the annulus, so the right coronary and left coronary cusp side, I pace at 120 to 140, depending on the patient. I then go a little faster until I go to just above 80%, the point of no return. At that point, you then go into an LAO view and try and get rid of all the parallax on the valve, and then do another aortogram in that view to make sure that the left coronary cusp side is not too low. If I like it in both these views, at that stage, I do a slow release of the valve.
Perfect, crystal clear. So maybe one question for you, Dan. We've seen that Azim tried to and did succeed in cannulating the left coronary artery post-procedure. You did that, Azim, for the sake of the recorded case and for teaching purposes. But Dan, don't you believe that this could be a routine practice, because we are treating a greater number of patients, and some of them are going to return in non-TAVI centers for example, an acute myocardial infarction. So isn't it an additional piece of information if we, at baseline, try to illustrate where to cannulate, what is the projection, which diagnostic or guiding catheter we have utilized? Do you think that this could be systematic and more systematic in the future, just to help these non-TAVI implanters?
Didier, it's rare that I disagree with you, but I think I am going to on this occasion. I'm not sure I could support doing that routinely. It'd be unlikely that information would filter through to whoever the patient pitched up in front of in the middle of the night with a STEMI. So I think we should I think we should try and align the commissaires in every case. And we've got a good mechanism for doing it now, but I'm not sure we need to demonstrate how to cannulate the coronaries, because there's always some risk associated with it. Is tiny, of course, but I don't think you'll have operators wanting to do that routinely after they've done the procedure. I think we should focus on the commissure alignment, and I think it's been a big step forward. And we all know that it can be difficult to cannulate the coronaries with core valve Evolut platform. I think we've all probably had cases where patients have been turned up in district hospitals, surrounding peripheral hospitals, and they haven't been able to cannulate the coronaries. And TAVI, as TAVI implanters, we've learned tips and tricks on floating the wire in, following up with guide catheter extensions, etc. But I think this is a big step forward to make it easier to get in the coronaries with the Evolut platform. And of course, to come back to the issue of TAVI and TAVI in the future, that's going to be a lot more feasible with less risk of jailing the coronaries if we've aligned the commissaires at the primary procedure.
Words of wisdom. So Tanya, it's time to move to your lecture, and you're going to drive us through the benefits of the cusp overlap techniques in terms of outcomes. So the floor is yours.
Thank you so much for the kind introduction. These are my disclosures. Ladies and gentlemen, as you may appreciate from this slide, with the cusp overlap technique, we are able to elongate the LVOT, in particular as compared to the three-cusp coplanar view and the LAO view. This facilitates an accurate positioning of the TAVI prosthesis, in particular in regard to the non-coronary cusp, as shown here on the left-hand side. In order to reduce the interaction with the conduction system, we should try to attempt an implantation depth not lower than 3 millimeters into the LVOT. We should also try to start deployment at mid-pigtail, so the valve should travel into the aortic annulus during deployment. Various smaller, mainly monocentric studies have shown that the cusp overlap technique significantly reduces the permanent pacemaker implantation rate. However, so far, there is no multi-center study on this topic. The Optimize PRO study has the objective to collect clinical evidence on valve performance and procedural outcomes utilizing cusp overlap technique to deploy Evolut valves. I would like to share with you within the next few minutes the pre-specified interim analysis. The mean age of patients in the Optimize PRO study was 78%. And what you see, there was a roll-in phase where the centers were trained on the technique, and then patient went to the main cohort. And I basically will focus on the combined result. This was an overall low-risk patient cohort having an STS score of 2.9, and there was already in 6% of the patients a pre-existing right bundle branch block, the main risk factor for permanent pacemaker implantation. All-cause mortality and stroke was low, with being 5% in the combined patient cohort. There was no mortality, but only 5% of patients had a non-disabling stroke. Permanent pacemaker implantation rate was 8.8%. In summary, from the Optimize PRO study, we learned that with the cusp overlap technique, we are able to achieve excellent clinical outcomes. We can also achieve really low permanent pacemaker implantation rates. Hemodynamics are, as always, excellent with the Evolut prosthesis with a mean gradient of 8 and low PVL rate. There were no pop-outs, even though a high implantation position was being tried to achieve. And from the TBT registry and also from various other studies, we get a reconfirmation that cusp overlap technique significantly reduces the permanent pacemaker implantation rate. Thank you for your attention.
So Tanya, that was a very nice overview of the potential benefits of the cusp overlap technique and the PRO Plus platform, because in the Optimize PRO, it was mainly the vast majority of the patients were treated with a PRO Plus platform. Even though this is an interim analysis, one could expect that the outcomes could have been exceptional, as they are only for pacemaker rates and for conduction disturbances overall. But what we see is that even the more dreadful clinical outcomes like stroke, deaths, and so on are really, really decreased. And what is the explanation, to your opinion? What adds the technique to the prevention of such complications like stroke?
Well, I'm pretty sure that we learned a lot during the last decade regarding our implantation technique. And so, I mean, we see that in different registries and also in our randomized trials that the stroke rate and also mortality is going dramatically down. I mean, of course, this was a cohort having a low risk, even though the age was at the end 70s. But I think this is what we just would expect from a very good TAVI platform, that this is the numbers we are getting. And I think what was really confirming here is that the hemodynamics were so good. So, I mean, mild or trace PVL was achieved in 80% of the patients, and only 20% had mild PVL. There were no patients with moderate to severe. So this is a big step forward also in hemodynamics. And I think this just shows that if we achieve for a high implantation position, this also helps to reduce PVL.
And this is definitely the type of outcomes that we expect for lower risk patients to get exceptional hemodynamics and to get low pacemaker rates, early discharge. So definitely it matches the expectations for lower risk patients. So Azim, maybe one last question from the chat. What about the antithrombotic regimen for the patient?
Yeah, I think, based on popular TAVI now, we are only giving our patients aspirin post-TAVI. That's what we do. If they require anticoagulation, then for another reason, and they only get anticoagulation. So we've stopped using DAPT in our patients as routine.
Excellent. I think it's time to kind of wrap up, and I have to say that this was a very stimulating discussion because Evolut PRO Plus is just has just come to Europe, and we are learning more about the benefits of this platform, and we nicely had an overview of the new features of the platform. First, with the improvement in the delivery profile, allowing, as Dan has mentioned, to treat more patients with smaller vessels, as it was the case before with the past iteration of the Evolut R. We are now able to treat more patients with a suited platform. And then we have that wrap for the 34 millimeter, so we are going to be able to treat even more challenging anatomies, like, for example, bicuspid patients with large anatomy with a minimal risk of perivalvular regurgitation. Then we've seen, and we had a superb case, and the audience congratulated you, Azim, for the outcome for the patient. And you nicely demonstrated a contemporary technique combining the cusp of a lap technique and the commissural alignments. We had that step-by-step procedure description of how to achieve a proper commissural alignment in the cusp of a lap view. And so we had that. The objective was matched. And at last, we could understand through the presentation of the interim analysis results of the Optimize PRO study, of what we could expect in terms of outcomes for lower risk patients in terms of hemodynamics, clinical outcomes such as stroke, death, PVLIC reduction, and early discharge, because lower risk patients, younger ones, are going to be more mobile, and we need to take the quality of life into consideration. So, having said that, I'd like to thank you all for participating, for providing such good lectures and cases, Azim, Tanya, and Dan. I would like to thank Medtronic for supporting that TNT, and thank the audience for the quality of the interactivity, the level of the questions, and I wish you all a nice evening or afternoon, depending on the time zone where you are. Thank you, guys, and see you soon, face to face.
Bye.
Bye, everyone.
Bye.